Hello YouTube, welcome to my channel. In this video, we shall be discussing endometrial cancer from the Department of Gynecology. So endometrial cancer is a malignant disease of the uterus that is very common and having an age-related incidence of 95 per 100,000 women. The lifetime risk of developing endometrial cancer is approximately 1 in 46. That means the mean age of diagnosis is 62 years. Approximately 25% of endometrial cancers occur before menopause. So basically, this endometrial cancer involves a cancerous growth of the endometrium, and alternative names are endometrial uterine adenocarcinoma, uterine cancer, adenocarcinoma of the endometrium, and so on and so forth. So it's important to understand that endometrial cancers usually arise from the glandular component of the endometrium. And endometrial cancers are classified as type 1 or type 2, depending on their histological subtypes. And they are graded 1 to 3, with 3 being high grade, which means they're mostly abnormal cells. So type 1 tumors are endometrial adenocarcinomas that are estrogen driven and arise from a background of endometrial hyperplasia. Whereas type 2 tumors include high-grade serous and clear cell histological subtypes and arise from an atrophic endometrium. Now let's have a look at figure 15.1, where the image in A is the endometrial adenocarcinoma, and the image on B, that is labeled B, that is to the right, is endometrial serous carcinoma. So you can clearly see the differences that exist when we compare histological structures. When it comes to etiology, the exact cause of endometrial cancer is unknown, although increased levels of estrogen appear to play a leading role. Because we understand that estrogen's normal function is to stimulate the build-up of the epithelial lining of the uterus. Therefore, it's been suspected to have a leading role in the development of this cancer. Alright, for type 1 endometrial cancer, the risk factors are obesity, hypertension, diabetes, nulliparity, having late menopause, that is menopause that started after 52 years, unopposed estrogen therapy, tamoxifen therapy, in patients who have a family history of colorectal and endometrial cancer. And basically what we realize is that most of these reflect an increased lifetime exposure to estrogen, most of these risk factors, that is. And it's important to note that the risk factors for type 2 endometrial cancer are less well understood. When we talk about symptoms, number 1 on the list is disorders of menstrual bleeding. So that entails that bleeding between normal periods in premenopausal women and vaginal bleeding or spotting in postmenopausal women. And in addition, in women older than 40 years, extremely long, heavy, and frequent episodes of bleeding may indicate premalignant changes. So women at more advanced stages of the disease may present with abdominal pain, urinary dysfunction, bowel disturbances, or even respiratory symptoms. And other women will complain of white vaginal discharge in especially postmenopausal women. So for diagnosis and investigation, a transvaginal ultrasound allows a quick and accurate assessment of endometrial thickness. And if the endometrium measures less than 4 millimeters, cancer is very unlikely and further investigation is not needed. But any measurements greater than this requires further evaluation by hysteroscopy and or biopsy. So basically with hysteroscopy, a thin camera is passed into the uterine cavity, and this allows for visualization of the endometrium, and a biopsy is taken of any abnormal areas. So in addition, an endometrial sampler is used for histological assessment of the endometrium. after which a histology report will describe the type, if it's endometrial or other histological type. And histology results may also tell the grade of tumor. Now, in the next slide, the picture on the bottom, we see a hysteroscopic picture of the endometrial carcinoma. And above it, just above it, is a transvaginal ultrasound scan of the uterus showing a very thickened endometrium. Very characteristic findings. So when it comes to staging, we use MRI to tell the extent of the disease, and the slide that you're currently looking at is the figure stages that is used in most of these clinics. So stage 1 entails that the tumor is confined to uterine body. Then 1A entails that there is less than 50% invasion of the whole uterus. 1B entails that there is more than 50% invasion. Stage 2 entails that the tumor has invaded the cervix. Stage 3 entails that there is local and or regional spread of tumor. Stage 3A entails that the tumor has invaded Stage 3 entails that the tumor has invaded the serosa of the uterus. Stage 3B entails that the tumor has invaded the vagina and or the parametrium. In addition, stage 3C entails that there is metastasis to pelvic and or para-aortic nodes. And finally, stage 4 entails that the tumor has invaded the bladder, plus or minus the bowel, plus or minus distant metastasis. In this case, it would be the lungs that may be involved. So it's a protocol that patients with high-grade tumors undergo a CT, a computed tomography scan of the chest, abdomen, and pelvic in order to exclude distant metastasis. So for management, surgery is the treatment option that is taken and that is given. And in this case, standard surgery of total hysterectomy and removal of both fallopian tubes and ovaries, otherwise known as bilateral salpingo-phorectomy, is what is recommended. So this can be performed abdominally or laparoscopically. And in a case where MRI suggests cervical involvement, a modified radical hysterectomy is performed, which also removes a cuff of the vagina, paracervical and parametrial tissue to ensure adequate excision margins. In addition, if the tumor is high grade, that is grade 3 or of type 2 histology, many centers perform pelvic and para-aortic node dissection because nodal disease is seen in 1/3 of patients. In addition, abdominal hysterectomy is recommended over vaginal hysterectomy. This is because it affords the opportunity to examine and obtain washings of the abdominal cavity to detect any further evidence of cancer. Women with stage 1 disease who are at increased risk for recurrence and those with stage 2 disease are often offered surgery with radiation therapy or even chemotherapy may be considered in some cases, especially for those with stage 3 and stage 4 diseases. In other cases, hormonal therapy using progesterone may also be recommended. Alright, that's it from me. Thank you so much for watching this tutorial. If you want to support me, kindly subscribe to this channel and leave me a comment on what topics you would like for me to cover next. Thank you.